So after a very long time, we have started recording a video on nephrotic syndrome. So today we'll be talking about nephrotic syndrome, and nephrotic syndrome is a very important topic to be studied. Now, before studying about nephrotic syndrome, we need to understand that nephrotic syndrome means proteinuria, right? So proteinuria, basically, more specifically, it's albuminuria. Albuminuria. But not only albuminuria, there are various other parameters which should be taken under consideration when we talk about nephrotic syndrome. So nephrotic syndrome is a clinical complex. It's a clinical complex. It's characterized by proteinuria. Okay. Number one, it's proteinuria. So proteinuria, what amount of protein is needed in the urine? It is more than 3.5 grams in 24 hours. In 24 hours. So this is the definition of proteinuria. Okay. Now, if you talk about proteinuria, so it's the first one is the proteinuria, right? So this proteinuria can be a normal proteinuria, or it can be a mild to moderate, or it can be a massive proteinuria. So how are we going to say that this is a normal? If it's less than 4 mg per meter square per hour, 4 to 40 mg per meter square per hour, or it can be more than 40 mg per meter square per hour. So this gives you the actual value, actual understanding of what is uh, said to be a significant proteinuria. Okay, we can also go for a dipstick test for the proteinuria. Okay, so if you talk about the dipstick test, it's very easy to understand. See, trace 1 plus 2 plus 3 plus 4 plus. Okay, so remember, it's very easy. So 3 is 3 gram per liter. Okay, so 4 must be more than 3, so it's 10. Okay, it's 10 gram per liter. If you look at this 2 and this 1, see, 1 it will be exactly, just understand in this way that this 2 will be less than 3, so it will be 1 gram per liter. Okay, and trace means 0.1 gram per liter, and 1 plus means 0.3 gram per liter. So if you memorize the value for 2 plus being 1, trace 0.1. Okay, 1 plus it is 0.3, 3 it is 3. Okay, so it's very easy. Proteinuria, 4 to 40 and more than 40, just the multiples of 4. Okay, it's not difficult. Okay, so it's more than 3.5 grams per unit, more than 3.5 grams in 24 hours. If you have proteinuria, that is a significant proteinuria. Okay, now there'll be hyperalbuminia, there'll be edema, there'll be hyperlipidemia, there'll be lipiduria, and there'll be hypercoagulopathy. So understand these things very well clear. Okay, so if there is hypoalbuminia, what will there be? The plasma colloid oncotic pressure. The plasma colloid oncotic pressure, because of lack of albumin, will be low. And we all know from our first chapter, I think fourth chapter or fifth chapter in Robbins, there's increase in the hydrostatic pressure, decrease in the plasma colloid oncotic pressure. The fluid is not able to imbibe here into the vessels. So what will happen? The fluid will be more in the interstitial space, and what is that known as? Edema. Very good. So edema, it starts from the periorbital region, and it can go, and it can involve the whole body. Okay, the whole body can be edematous, but first it's the periorbital region. Okay, there can be hyperlipidemia. So what is this concept? So we all know that whenever there is decrease in the level of albumin, okay, there's less albumin, so the body tries to compensate. The body tries to compensate by increasing the level of VLDL, okay, VLDL from the liver, and this tends to increase in the level of triglycerides, okay, and increase in the level of circulating free cholesterol. So that leads to lipidemia, and that lipid, if it goes to the urine, it's lipiduria. And hypercoagulability. So what happens is antithrombin 3. So antithrombin 3, we all know antithrombin 3 means thrombin is a procoagulant. So if it's an anti, that means we are not allowing procoagulant to happen. Okay. So if antithrombin 3 decreases, what will happen? There will be more coagulation. So what happens? Because of more amount of antithrombin 3, there will be more coagulation. Okay. Of course, there is said to be, as there can be anemia also, then there can be thyroid disorders also. Thyroid hypothyroidism. Anemia, it's because of the anemia. Thyroid disorders is because of the loss of thyroglobulin. Okay. Anemia can also happen secondary to this one, because we all know that anemia, it's more prominent when there is CKD, because there is no erythropoietin to be released. Okay, so in the CKD it's more important. Okay, now let's talk about this glomerular pathology. And in glomerular pathology, we need to understand that, so it can be a primary glomerulonephritis, or it can be a secondary glomerulonephritis. Okay, so primary glomerulonephritis, you can see that minimal change disease, focal segmental glomerulosclerosis. You can see that proliferative glomerulonephritis, myeloproliferative glomerulonephritis. So these all are actually, this MPGN and PGN falls under your glomerulonephritis as well as nephrotic syndrome, both. Okay, but minimal changes and focal segmental glomerulosclerosis are classically, they are the nephrotic syndromes. Secondary, it can be secondary to various conditions. So number one is foremost is the chronic illnesses like hypertension and diabetes. Chronic illnesses like hypertension and diabetes. It can happen secondary to infections. Okay, infections. What infections? It can happen because of malaria, because of syphilis, because of hepatitis. Okay. Now, certain diseases like systemic lupus erythematosus and amyloidosis, SLE and amyloidosis can also lead to glomerular diseases. Okay, this glomerular disorders. Certain drugs like gold, heroin, penicillamine can also lead to glomerular disease. Okay, nephrotic syndrome. Now, what are the clinical features? Of course, the clinical features, you all know that there will be edema, swelling. Remember, there won't be any kind of hematuria. Okay, so if there is hematuria, so what is hematuria? Hematuria means if you are able to see more than 5 RBC per high power field, that is known as hematuria. Okay, red urine can be because of various other causes. What are the other causes of red urine? So it can be because of beetroot ingestion, it can be because of myoglobinuria or hemoglobinuria. Okay, so here we are concerned about the quantitative value, that is more than 5 RBC per high power field is known as nephrotic syndrome. Okay, is known as, sorry, hematuria. Okay, so the urine output will be normal, so there will be a normal urine output. But in the case of glomerulonephritis, which we'll be talking certainly, there will be reduction in the urine output, and that is our major concern. Okay, BP will be normal in this case. There will be hypercholesterolemia, hyperalbuminemia, lipiduria, and hypercoagulability, right? So there is proteinuria. So there is proteinuria, right? We all know that. Why is there proteinuria? Because there is hypoalbuminemia, decrease in the plasma-collated oncotic pressure, and there is edema, right? So what happens when there is hypovolemia? So there is hypovolemia, isn't it? So if the interstitial spaces consist of fluid, but the intravascular space is not consisting of any kind of fluid, so that hypovolemia, it will decrease the renal perfusion and it will activate the renin angiotensin pathway, and there will be sodium and water retention. Okay, sodium water retention. And in nephrotic syndrome, the edema is due to activation of the renin-angiotensin aldosterone mechanism. Okay, so both mechanism you can take under place. Okay, so because of decrease in the plasma colloid oncotic pressure, there is edema number one. Number two, what will happen is because of hypovolemia, there will be activation of the renin-angiotensin and there will be retention of sodium water. That will also lead to edema. Proteinuria. Normally, the glomerular basement membrane is negatively charged because of glycosaminoglycans, right? So the positively charged particles are filtered through the glomerular filtration. In nephrotic syndrome, this negatively charged becomes positive, so many urinary loss of the proteins takes place. The main one being albumin. Okay. Now there is damage to the glomerular basement membrane. So, of course, there are some this podocytes, right? Podocytic cells, and there is a damage to the glomerular basement membrane. So if there is effacement damage of these porocytic cells, what will happen? There will be more and more amount of albumin going to the urine, right? So hypercholesteremia, I already told you that reflects increase in the level of VLDL and decrease in the level of lipoprotein lipase. Lipoprotein lipase was responsible for converting lipids into free fatty acid and glycerol. Okay, this free fatty acid is very much toxic. Okay, so if this free fatty acid is in very much excess, what will happen? Patient can land up into diabetes. Okay, so the patient can present with respiratory insufficiency. As we all know that nephrotic syndrome can lead to transudate type of pleural effusion. So there might be a bilateral pleural effusion, lot of fluid in this one, and if there is a lot of fluid in this one, pleural space, it might push the lung. Okay, collapsed lung may be seen. And because of collapsed lung, what will happen? Respiratory insufficiency, right? Insufficiency. Now, hypercoagulability, as I already told you, it's because of. Now, remember that there is ascites. This ascites can land up into spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. So, we will be talking about certainly about spontaneous bacterial peritonitis. And loss of factor 8 and 9, bleeding, hypercoagulability due to increased fibrinogen, decrease in the antithrombin 3. Main is decrease in the level of antithrombin 3, okay? So what will happen? Increase in the level of factor 5, factor 7 and 8, and that will lead to coagulation, right? Of course, there will be increase in the drug toxicity. Why? Because the albumin is now less. So if the albumin is less, drugs which is binding to albumin can't do so. So the free form of the drug will be more, and that will be increase in the drug toxicity. Okay. And there will be pre-renal azotemia. As I already told you, since there is hypovolemia, the kidney tries to really take in more sodium and water, and there is hypovolemia, right? So how are you going to investigate to this case? Just go for a urine culture. Urine routine RME must be done. Look for any kind of pustules. Look for secondary UTI, because the child has been now immunocompromised, right? So immune status has gone down. So just look into the epithelial cells, pustules in the urine, right? Most important is 24 hours urinary protein. So if this is not possible, you can just go for albuminuria. Okay, and serum albumin, just look for the serum albumin level. Okay, look for the coagulation profile, PTINR, right? Go for USG abdomen. Look for any signs of ascites. How large is the fluid? How much is the fluid? Go for a chest X-ray. Rule out pleural effusion, right? These are the things that you're going to write, okay, in your exam paper. You have to also look into the serum C3, C4. So you might have missed a case of post-septal glomerulonephritis or Alport syndrome. So this might be there, and if PSGN is suspected, serum C3, C4 will be decreased. In Alport syndrome, no change. Of course, in nephrotic, there is no change. There is no change. Okay. Now we all understood. Now let's talk about the treatment strategy. So the most important is the treatment strategy, and before going to the treatment strategy, you should know some terminologies which is related to nephrotic syndrome, and this is going to be the most important. This is going to be a most important slide. Okay. So remission. So what do you mean by remission? Remission means urinary protein. Please write it down. Okay. Urinary protein becomes trace or nil for 3 consecutive samples. Okay, so what does this mean? So you take 3 samples. Okay, 3 consecutive samples. Now this shows we already learned trace 1 plus 2 plus 3 plus 4 plus. I always write it from down. I don't know why, but I really like writing from down. So if it's 10, so this is 3 gram per liter, 10 gram per liter, 0.1 gram per liter. So if it's a 2, it's a 0.3 gram per liter. Sorry, it's a 1 gram per liter. And here it's a 0.3 gram per liter. So I often write it in this way, right? So trace proteins, trace or nil means it is plus trace or nil. Trace means 0.1 gram per liter, but trace or nil protein will be there for 3 consecutive samples. Okay, that is important. Now, what is relapse? And what is frequent relapse? So what is relapse? Relapse means, see, if someone asks you about glomerular disease, please just don't write. Please just don't write minimal change disease and focal segmental glomerulosclerosis. Also write about SLE, PAN, diabetes, hypertension, okay, amyloidosis, infections, malaria, hepatitis. These also lead to nephrotic syndrome. Okay, great. Now, what is relapse? Relapse means urine protein. Now it becomes 3 plus 4 plus. So if it becomes 3 plus 4 plus, it is a relapse. Now frequent relapse is slightly different. So if there is more than 2 relapses during the 6 months period, okay, 6 months period. So frequent relapses means in 6 months there is more than 2 relapses, right? Now we talk about steroid dependent nephrotic syndrome. So what is steroid dependent nephrotic syndrome? More than equal to 2 relapses during alternate day therapy of steroid. Okay. So more than equal to 2 relapses during alternate days. Suppose I give steroid today and I'm giving, so how am I going to plan this treatment? Okay. So during the planning of this treatment, during the planning of the treatment for nephrotic syndrome, I'm going to give oral prednisolone. Okay. I'm going to give oral prednisolone and I give it 2 mg per kg, okay, for 6 weeks. And again, I reduce it to 1.5 mg per kg daily. Okay, this is also daily. Okay, for 6 weeks. Then I stop it. Okay, so this alternate day therapy means this one. Okay, means every day, every other day, you're going to give this one, and this you are going to give daily, right? So when you are going to give this condition, if there is more than or equal to 2 relapses during the alternate day therapy, then that is steroid dependent. If just asked relapse, what is a relapse? Relapse means 3 plus 4 plus, that's a relapse. Or if it is just asked to you that what is a there is a relapse, 3 plus 4 plus. Okay, now it's just asks that frequent relapse. Frequent relapse. So if you ask frequent relapse, 3 plus 4 plus in 6 months. Okay, frequent relapse means more than equal to 2 relapses in 6 months period. Okay, frequently it's relapsing. Okay, and now steroid dependent. Steroid dependent means totally dependent upon steroid. What does that mean? That means the person is totally dependent upon steroids. Totally resistant for steroids. Steroid resistant cases. Steroid dependent means whenever you are going to give an alternate therapy, there is a relapse. That is a steroid dependent. Okay, that is a steroid dependent. Steroid resistant means so during a 8-week therapy. So you're giving a 8-week therapy and there is a steroid resistance. Okay, that means 8-week therapy, you are giving 8-week therapy, and after you give a 8-week therapy, the person becomes steroid resistant. The person is not working with steroid. That is steroid resistant cases. So for that case, it's better you go for a calciurin inhibitor. Okay, calciurin inhibitors. Okay, now I will tell you about this drug dosing again. So you got it right. What to write? Remission, relapse, frequent relapse. So remission means, once again let us revise. Remission means, so we say it remission. When do we say remission? Remission means, so if the person shows 3 doesn't show this higher protein urea, he will only show trace or nil protein. Okay, so that in the 3 consecutive samples, that is remission. What is a relapse? Relapse is divided into 3 types. One is relapse, frequent relapse, and it's a steroid dependent case. So relapse is actually 3 plus 4 plus protein. If it's seen, that is relapse. Okay, if it's said a frequent relapse, 6 months period, you have 2 relapses, that is frequent relapse. Steroid dependent, more than equal to 2 times failure in alternate day therapy. Okay, more than equal to 2 times relapse. Relapse means 3 plus 4 plus. In alternate day therapy, that is steroid dependent. And steroid resistant means they're totally dependent upon steroid. And now steroid resistance, steroid is also not able to control. Like 8 weeks of therapy is given and the steroid is also not able to control. So what is the other important question that is asked? So what is the indication of renal biopsy? Indications of renal biopsy in nephrotic syndrome. So what is the indication of renal biopsy in nephrotic syndrome? So the indications of renal biopsy in nephrotic syndrome. So what's the indication of renal biopsy in nephrotic syndrome? So what are you going to do is, if the age is less than 1 year, okay, if the age is less than 1 year, so if there is hypertension or hematuria present, okay, present, if there is low serum C3, steroid resistant cases, there has been shown a sign of oliguria, or there's a history of nephrotoxic agent used. Okay, so slightly different. Whenever we talk about nephrotic syndrome, this becomes the indication of biopsy. In the case of nephritic syndrome, slightly different. In the case of nephritic syndrome, if oliguria is for more than 7 to 10 days, so here just if in case you see oliguria, you're going to go for biopsy. Okay, your oliguria for more than 7 to 10 days if seen. Next, if there is a low C3 for more than 12 weeks, okay, so for 12 weeks you're giving time so that at least the C3 comes up. But until and unless this 12 weeks also, the C3 is still low. But here it's just low C3, okay? It is C3, both cases, but here in the nephritic syndrome, you need to classify also, okay? So low C3 for more than 12 months is known as nephritic syndrome. In nephritic syndrome, it shows a subepithelial deposit. So subepithelial deposit, what do we see? What do we consider? It might be PSGN, right? So subepithelial humps we say, right? So it's also known as a lumpy bumpy appearance, okay? So whenever we talk about nephritic syndrome, slightly different than nephrotic syndrome, there is there is no massive proteinuria. There might be moderate proteinuria. So proteinuria might just be 4 to 40. 4 to 40, mild to moderate type of proteinuria, 4 to 40 may be there. Massive more than 40, if there is massive, there will be massive ascites also, okay? Now we talked about the treatment of nephrotic syndrome, and we talked about the um, specific treatment. Now I would like to tell you about some additional point which has to be kept during your institutional examination. So rest and fluid. So how much fluid we want to give to the patient? So if, okay, today is Sunday, tomorrow is Monday. So Sunday the person urinated 500 ml of urine. So Monday you should be given 500 ml of fluid. That's it. Okay, don't give much more fluid. If this becomes a scenario if he has no edema. Okay. Sorry, this becomes a scenario if he has edema. Okay, if he has edema. In the presence of edema, the fluid must be equal to the urine output. Okay, but this should be less than 100 ml per day in the case of edema. So if there is no edema, okay, once edema subsides, okay, then fluid intake should be, you can add 500 ml to the previous day urine output. Suppose previous day your urine output was, if in case previous day your urine output was 900 ml, okay. Now today you will give 900 ml. If I am giving today 900 ml, so what is this? What is this? This is a case of edema. So if there's edema, if you're giving 900 ml of fluid, then you just give 900 ml of fluid again. But if there is no edema, you can add upon a 500 ml extra. 500 ml extra can be added, okay? So we complete this fluid component. Now let's talk about protein, sodium, potassium, okay? So strict restriction is not needed for sodium because this is not a nephritic syndrome. In nephritic syndrome, it's better to give less sodium. You know why? Because, nephritic syndrome consists of hypertension, but here there's no hypertension, right? Now, pulmonary edema will be there. Others, you can take it normally, okay? There's no protein, you don't need to restrict. Just restrict the fat, okay? Because there is lipidemia and lipiduria, so don't consume fatty food, okay? Next is Next is your fluid. So for the fluid, there's pulmonary edema, so you can give furosemide. Okay, furosemide. Okay, and next thing that you need to remember is diuretics won't work if there is hyponatremia and hypoalbuminemia, so should be corrected first. Furosemide should be given with spironolactone, which increases the potential and balances the potassium loss. Okay, and if you give protein binding drugs, mainly warfarin, suppose a person was a case of AFib and he developed amyloidosis, he developed nephrotic syndrome. So warfarin must be on a close monitor. We don't want INR. We want to INR to be at least like 2. Okay, we don't want it to go more. Okay. So monitor. It's better to give low molecular weight heparins, or it's better to give novel anticoagulants like rivaroxaban. Now, spontaneous bacterial peritonitis can happen, so it should be treated with proper antibiotics, right? I'll be talking about spontaneous bacterial peritonitis soon, okay? And I already talked about how are you going to treat in the case of steroid dependent. So if you are asked how are you going to treat a case of steroid dependent nephrotic syndrome, frequently relapsing nephrotic syndrome, or relapse plus nephrotic toxicity, steroid toxicity is there, so you are going to give steroid sparing agent cyclophosphamide, levamisole. Okay, levamisole. And regarding vaccination in nephrotic syndrome, the killed vaccine is safe, but live vaccine is relatively contraindicated. So OPV is not even given to siblings. Okay, but pneumococcal and varicella must be given. Okay, so killed vaccine it is safe. The live vaccine, it's relatively contraindicated. OPV, don't even give it to siblings. Okay, don't even give it to siblings. So if it's case of relapse means 3 plus 4 plus, right? So if the urine protein is 3 plus 4 plus, you can start again with steroids, methylprednisolone or oral prednisolone, 2 mg per kg for 2 weeks, alternate day 1.5 mg per kg for 2 weeks. Okay, alternate day therapy. So 2. Initially it was 6 is given as a whole nephrotic syndrome. Later it's given as 2. Okay. So sometimes the question is asked as write the treatment for nephrotic syndrome. So you can write levamisole cyclophosphamide is given in the case of steroid resistant or a steroid dependent cases. Okay, or frequent relapse also you can give the same treatment. Okay. Indications of biopsy has been discussed, right? So this completes our video on nephrotic syndrome. Next video will be on nephritic, hematuria, proteinuria. Okay, we'll discuss everything.